I'm Dr. Seshadri. I'm one of the medical oncologists. I've been here since 2009. Neoadjuvant, the word means that you do something before their definitive treatment. And for bladder and kidney, the definitive treatment is surgery. So we come along and we try to do something before they can have the surgery. It is more done in bladder. We don't do that in kidney cancer. And the same way, the adjuvant means in addition to the surgery. So after they have had the surgery, then we come in and do some treatments. That treatment could be anything: chemotherapy, immunotherapy, targeted therapy. There is just a whole variety of opportunities.
My name is Matthew Rutter. I'm a urologist and I've been at Graves Gilbert Clinic for 12 years. So it really kind of depends on why the patient was referred to us with respect to how we have diagnosed cancer. Some patients may have blood in the urine. Well, when somebody's referred to us for blood in the urine, we need to get a CAT scan to look at their kidneys and their ureters. We also look inside their bladder with a scope to look for bladder tumors. Some small bladder tumors won't show up on a scan, but we can see them by just simply looking inside. But many of the cancers we find are also incidentally identified. Patient comes to the emergency department with abdominal discomfort and they got an ultrasound to look at their gallbladder, and lo and behold, they find a kidney tumor. Or maybe they had a CAT scan for some other reason and the scan might incidentally show a tumor somewhere.
So the patients who usually have stage 2 or stage 3 bladder cancer. So sometimes the cystoscopy is not able to determine that, and then they go take them to the operating theater, get a deeper biopsy to see what are the levels and layers through which the cancer has gone through the bladder wall. And those patients will be able to get treatment with us for the treatment before surgery, the neoadjuvant. The idea of doing this neoadjuvant is to reduce the spreadability of the cancer, and also to make the surgery much more feasible. You don't want to operate on someone that they're going to have a chance that it's going to come back, very high chance of it coming back. So we want to give the patient a chance to keep their bladder. That's one of the bigger goals. The second big goal is to reduce the chance that the cancer will come back. So those are our two goals, and that's why we want the stage 2 and the 3 cancers.
So the idea with neoadjuvant therapy, and quite frankly, the best benefit for that is to change the stage of the tumor. If we can decrease the stage from, let's say, a stage 2 or a 3 to a stage 1, then we can more likely surgically remove all of the tumor and the patient's long-term survival will be better. If we did the surgery first and find out the patient had a stage 3, their risk of recurrence is much higher and their longevity may not be as good. With the adjuvant treatments for kidney cancer, usually we use those in the event that cancer has already spread somewhere else. And if it's already spread somewhere else, we can't surgically remove everything. And the adjuvant therapy may buy them additional time and improve their overall survival. So after we've treated the patient, both surgically and with chemotherapy or immunotherapy, we follow these patients very closely. And we use the typical NCCN guidelines to help us determine for each type of cancer how we follow them. And we want to identify recurrences early so we can treat them early and keep them alive as long as we can.
I think survival is our ultimate goal, and quality of life is a very important thing for us.